Hi everyone, this is Merrina again. Today we'll be reading the very last chapter of Better by Atul Gawande. Last time we did chapter 10, which was about cystic fibrosis programs across the country and how ranking those programs based on performance and then trying to improve their strategies was like helping more patients. Today we'll be reading the last chapter. It is called For Performance. I was in the operating room doing surgery one day, and across the drapes on the anesthesia team was Dr. Mark Simon, a 29-year-old resident. This was not a difficult case, so we got to talking. I mentioned the cystic fibrosis program that I've been thinking about, and it turned out the discussion hit closer to home than I'd realized because Mark has cystic fibrosis. I had no idea. Although we have been in on many cases together, and he has the short stature and raspy cough one often sees in people with the disease. The illness has been a tremendous struggle, he told me. He managed to stay healthy through his first 3 years of medical school. But in his 4th year, his disease progressed, and he has to be hospitalized for 4 weeks. The next year, in Boston, in residency, he had to miss 6 weeks. Now, only halfway through his 2nd year, he had already been hospitalized another month more. He has become, at 29, all too aware that the average life expectancy for a person with CF is just 33 years. So the question we got talking about was, what is more likely to save his life? Investment in laboratory science or in efforts to improve how existing medical care performs? The answer most people would come to is investment in laboratory science, the search for a cure. And in 1989, when scientists discovered the gene for cystic fibrosis, that would have seemed a wise choice. A cure was believed to be only a few years away. Dramatic progress, however, did not occur. Mark has not let go of the hope that a cure will be found, but he was not putting any bets on that happening in time to help him. Instead, he said, his hopes were focused on efforts to monitor and improve and transform clinical performance using know-how already in existence. He believes that all of the work being done, this was the work that was going to save more lives, and I agreed with him. To be sure, we need innovations to expand our knowledge and therapies, whether for CF or childhood lymphoma or heart disease or any of the other countless ways in which the human body fails. But we have not effectively used the ability science has already given us. And we have not made remotely adequate efforts to change that. When we've made a science of performance, however, as we have seen with hand washing, wounded soldiers, child delivery, thousands of lives have been saved. Indeed, the scientific efforts to improve performance in medicine, an effort that at present gets only a minuscule proportion of scientific budget, can arguably save more lives in the next decade than bench science, more lives than research on the genome, stem cell therapy, cancer vaccines, and all the other laboratory work we hear about in the news. The stakes could not be higher. So this part is very insightful because when we think about curing some disease, we would, do research and work in labs and stuff, but actually, making sure that the technology we have right now are being used correctly, it seems like an easier and more effective way to save lives than trying to discover something brand new and then figuring out how to use that new piece of information to make a change. Consider breast cancer. Rates of death from breast cancer have fallen by about 25% in industrialized countries since 1990. A study from a U.S. breast cancer registry recently showed that at least a quarter, and likely more than half, of that decline was due simply to increased use of screening mammography by women. Mammography saves lives by allowing breast cancer to be caught and treated while they are still small, before they can even be felt, and hopefully before they have spread. But the key to its working is that women faithfully get a mammogram once a year. Less often leaves too much time in between for a breast cancer to form, grow, and spread undetected. So how many women get their mammograms annually? Over 5 years, 1 woman in 7 does. Over 10 years, just 1 in 16. The reasons are various. Women themselves are often blamed, but the most important underlying factors include how time-consuming, uncomfortable, and difficult it is to get a mammogram, how inconvenient the facilities often are, how expensive the mammography is for those without insurance coverage, and how rarely reminders are given. The United States government and private foundations spread close to $1 billion a year on research for discovery of new treatments in breast cancer, but little on innovation to improve the ease of and access to mammography screening. That is very interesting. The government spends a lot of money to find how to cure cancer, but an easy and effective way to detect cancer isn't used as much as we hope it to be. And I totally understand that it is difficult for every woman to keep in mind that they have to do this every year. Like, they can be busy, they have kids, they have jobs, and it costs money. So I wonder how we can improve on that situation. Nonetheless, studies consistently show that more regular use of this one technology alone could help reduce deaths from breast cancer by 1/3. This is just one example of what improving performance in medicine could achieve. I did not completely fathom the full breadth of the possibilities. However, until I discovered the practice of medicine in most of the rest of the world, where the best hope for saving lives lies in raising performance, not in expanding genetics research. In 2003, I had just finished my surgical training, and before starting my practice in earnest, I decided to travel as a visiting surgeon to India, my ancestral home. In the course of a 2-month tour, I worked in a series of 6 public hospitals across the country, from 2,000-bed referral centers to rural cottage hospitals and ordinary general hospitals, usually 1 or 2 weeks at a time. One of the hospitals I visited was the district hospital that served Uti, the village that my father comes from. Uti is 400 miles east of Mumbai in the state of Maharashtra and directly north of Karnataka, where I witnessed the polio mop-up. Most of my father's family is still there. He is one of 13 brothers and sisters. They are farmers. Sugarcane, cotton, and a type of wheat called jowar are their cash crops. Drip irrigation has allowed them 2 crops a year, and along with the money my father sends, that has provided them with a degree of prosperity. Uti has a paved road and electricity. A few houses have running water. Malnutrition is no longer an issue. If the villagers get sick or need a checkup, there is a primary health center with a doctor who comes once a week or so. If they have malaria or a diarrheal disease, he sends them to the cottage hospital in Umarkhed, the small town nearby. Anything more serious, and he sends them to the district hospital in Nanded, 70 miles away. This is where my cousin went with his kidney stones. Just reading this part reminds me that although we live in a place where malnutrition and healthcare are seemingly pretty accessible, it is not the case in many other parts of the world. In Nanded Hospital, however, is the lone public hospital serving a district of 1,400 villages like Uti, a population of 2.3 million people. It has 500 beds, 3 main operating rooms, and I found when I visited just 9 general surgeons. Imagine Kansas with just 9 surgeons. Its 2 main buildings are 4 stories high and made of cement and beige stucco. The surgeons arrive each morning to a crush of several hundred people pressing their way into the outpatient clinics. At least 200 of them are there for the surgery clinic. The inpatient surgical ward are already full. Calls to consult on patients on other services seemed never to cease. And the puzzle to me was, how do they do it? How do the surgeons possibly take care of all of the hernias and tumors and appendicitis cases and kidney stones, and manage to sleep, live, and survive themselves? In the clinic one ordinary morning, I accompanied Dr. Ashish Motwar, a general surgeon in his late 30s, on duty that day. He had a black Tom Selleck mustache, khaki pants, and a blue Oxford shirt, open at the neck. He did not wear a white coat. His only equipment was a pen, his thin, almost delicate fingers, and his wits. The clinics at Nanded were like those I found elsewhere in India. They were ovens in the heat of the summer. The paint flaked off the walls in jagged stripes. The sinks were stained brown and the faucets didn't work. Each room had a metal desk, some chairs, a whirling ceiling fan, torn squares of blank paper under a stone for writing prescriptions, and at any given moment, 4, 6, sometimes 8 patients jockeying for attention. Examination took place behind a thin rag curtain with gaping tears in it. Wow. It seems like there really aren't enough doctors for for the patients, and the patients can barely get any privacy with just a rag and with tears on it. In 1 hour, Motwar saw a 60-year-old farmer complaining of weight loss, loose bowel movements, and a left upper quadrant abdominal mass, a teenage boy with a hot, swollen abscess above his belly button where he had been knifed, and 3 people with right upper quadrant pain, 2 of whom have confirmed gallstones, according to the ultrasound reports they brought with them. A bashful 31-year-old auto rickshaw driver came in with a walnut-sized tumor growing in his jaw. A turbaned, limping 70-year-old man dropped his trousers to reveal an aching, incarcerated hernia in his right groin. My father brought his 7-year-old boy in with what turned out to be a rectal prolapse. A silent, scared woman in her 30th undid her sari and uncovered a cancer the size of a child's fist growing into the skin of her breast. In total, Motwar saw 36 patients in 3 hours that morning, but he was calm despite the chaos. He would smooth down his mustache with his thumb and forefinger and peer silently over his nose at the papers people thrust before him. Then he would speak in a low and quiet way that made one listen carefully to him. He could be brusque at times, but he did what he could to give everyone at least a few moments of individual attention. With no time for a complete exam, a good history, or explanations, he relied mainly on a quick, finely honed clinical judgment. He sent a few patients out for x-rays and lab tests. The rest he diagnosed on the spot. He summoned a resident to drain the teenager's abscess in an adjacent procedure room. He instructed another resident to schedule the patient with gallstone and hernia for surgery. A woman with diarrhea and abdominal pain. He sent home with medication for the worms. I was especially struck by his treatment of the woman with the eroding breast cancer. Before arriving in India, I had assumed that this complex, expensive treatment such advanced cancers require, chemotherapy, radiation, surgery, would be beyond the system's capabilities and that the doctors would simply send patients like her home to die. But the surgeon did no such thing. It was unacceptable. Instead, he admitted the woman directly to the hospital and started her on chemotherapy that same afternoon himself. As a surgeon, I have no idea how to safely administer chemotherapies. In the West, this is something considered so difficult that only oncologists knew how to do it. But Indian manufacturers produce cheap, often pirated versions of most drugs, and everywhere I went in India, surgeons had learned how to dose and administer them. Cyclophosphamide, methotrexate, and fluorouracil themselves in makeshift treatment rooms of benches and folding chairs. They made compromises out of necessity. They did not monitor blood counts for complications the way we do in richer countries. They gave the drug through peripheral IVs in the patient's arm, rather through the expensive central venous lines that we use to protect the patient's veins from caustic drugs. But they got the patients through. The same was true for the radiation the patients needed. If they had a working cobalt-60 unit, the kind of radiation therapy unit used in the United States in the 1950s, the surgeons planned and delivered the radiation themselves. If a tumor responded, they performed surgery. It was textbook treatment devised by other means. It is very interesting to learn that in the less developed countries, medicine seems to be performed at the same level, and it was just with like cheaper things, and the doctors are doing many different procedures instead of in the U.S. The healthcare system is very much divided and specialized, and with each doctor only allowed to do certain things. I've actually talked to this alumni from my school. She's a nurse who has worked with Doctors Without Borders in Africa, and she likes being there instead of in the U.S. because over there they don't have a lot of resources, but they can do so much for so many people. But she doesn't think that in the U.S., like all the resources we have, we're still not offering the same level of good treatments. There was, I soon realized, nothing especially exotic about the troubles most people came to surgeons with, and this in itself was revealing. In the cottage hospital outside of my father's village, half of the patients were admitted for diseases we do not often see in the West: waterborne diarrhea, tuberculosis, malaria, but it is unusual for them to die from such illnesses. Primary care has improved considerably, and living standards have too. The average lifespan of Indians have increased from 32 years a few decades ago to 65 years today. Two of my aunts are 87 and 92 when I visited, and still able to walk their fields. My grandfather finally died at 110 years of age. He fell off a bus and developed a cerebral hemorrhage. Oh my gosh, this is amazing. They lived to 110 years old. If he didn't fall off a bus, then he might even live longer. People continue to get cholera and amoebiasis, but they recover. And then they face what we face: gallbladder problems, cancer, hernias, car crash injuries. The number one cause of death in India is now coronary artery disease, not respiratory infections or diarrheal disease. And most people, even the illiterate, knew that medicine can help them survive the new afflictions. The healthcare system, however, was not built to manage such illnesses. It was designed primarily for infectious disease. The Indian government's annual healthcare budget is just $4 per person, is woefully little for infectious disease, and impossibly inadequate for something like a heart attack. Improving nutrition, immunization, and sanitation remains a deserved priority. Yet the tide of people needing surgery and other kinds of specialized care does not stop. At least 50 of the 250 some patients seen by the surgeons in Nanded that morning turned out to need an operation. The hospital had operating rooms and staff, however, for only 15 such operations per day. Everyone else had to wait. This was the case everywhere else I visited. I spent 3 weeks as a visiting surgeon in Delhi's All Indian Institute of Medical Science. Delhi is a spacious and rich city by Indian standards, with broadband, ATMs, malls, and Hondas and Toyotas jostling with the cows and rickshaws on the 6-lane asphalt roads. The hospital is among the country's best-funded, best-staffed public hospitals. Yet even it has a waiting list for essential operations. One day I accompanied the senior resident charged with supervising the list, kept in a hard-bound appointment table. He hated the job. The book recorded the names of 400 patients awaiting surgery by one of the 3 faculty surgeons on his team. He was scheduling operations as long as 6 months into the future. He tried to give patients with cancer the first priority, he told me, but people were constantly accosting him with letters from ministers, employers, and elected officials insisting that he move their cases up in the schedule. By necessity, he accommodated them and pushed the least connected even further back the queue. While I think this could be problematic because people who don't have good connections with higher up people, or they might not get their surgery until like several years from when they're supposed to get it because the demand is so high. The hospital in Nanded did not have anything as formal as a waiting list. The surgeon simply admitted a patient with the most pressing cases and took them to surgery as space and resources became available. As a result, the 3 surgical wards overflowed with patients. Each ward has 60 metal cots lined up in rows. Some patients have to double up or take a place between the beds on the grimy floor. One day in the men's ward, 3 beds held one old man recovering from a repair of his strangulated umbilical hernia. A young man who had undergone midnight surgery for a perforated ulcer, and a bespectacled 50-year-old sick, waiting, as he had been for the previous week, to have a large inflammatory cyst that the pancreas drained. Across from them, on the floor, a man in his 70s crouched patiently, awaiting resection for his bleeding rectal cancer. 2 men nearby shared a bed, a pedestrian who has been hit by a car and a farmer who had been catheterized because of large stones obstructing his bladder. The surgeon took them as they could, operating through the day and rotating duties to continue through the night. In doing this, the surgeons were up against more than just the number of patients. Everywhere, they lacked essential resources, and they lacked a basic system that we in the West can usually count on to be able to do our jobs. I am still disturbed by the night I saw a 35-year-old man die from a perfectly treatable lung collapse. He had come to the emergency room at a large city hospital I had visited. I didn't know how long he had waited to be seen, but when I accompanied the surgical resident who was handed his referral slip, we found him sitting up on a bare cot, holding his knees, taking 40 breaths a minute, his eyes full of tears. His chest x-ray showed a massive fluid collection in his left chest, obliterating his lung and pushing his heart and trachea to the right. His pulse was rapid. His jugular veins were bulging. He needed immediate chest drainage to let the fluid out and allow his lungs to re-expand. Organizing this simple procedure, however, proved to be beyond our capacity. The resident tried draining the fluid with a needle, but the fluid was infected and too thick for the needle. We needed to put in a chest tube, but chest tubes, cheap and basic implements, were out of stock. So the resident handed the man's brother a prescription for one, and he ran out into the sweltering night to find a medical store that could supply it. Unbelievably, 10 minutes later he came back with one in hand, a 28 French straight chest tube, exactly what we needed. Shortages of supplies are so common that around any hospital in India you will find rows of ramshackle stands with vendors selling everything from medications to pacemakers. When we got the patient moved to a procedure room to put in the chest tube, however, no one could locate an instrument set with a knife. The resident ran to find a nurse, and by this time I was doing chest compression. The man was without a pulse on respiration for at least 10 minutes before the resident could finally put a scalpel between his ribs and let the pus shoot out. It made no difference. The man was dead. Wow, this is very sad that someone couldn't be saved because there were no supplies to help this person. Scarce resources were clearly partly to blame. This was a hospital of 1,000 beds, but it had no chest tubes, no pulse oximeters, no cardiac monitors, no ability to measure blood gases. Public hospitals are supposed to be free for patients, but because of inadequate supplies, doctors must routinely ask patients to obtain their own drugs, tubes, tests, mesh for hernia repairs, staplers, suture material. In one rural hospital, I met a pale 80-year-old man who had come 20 miles by bus and on foot to see a doctor about rectal bleeding from an anal mass, only to be sent right back because the hospital had no gloves or lubricating gel to allow the doctor to provide an examination. A prescription was written, and 2 hours later, the man hobbled back in, clutching both. Such problems reflect more than a lack of money, however. In the same hospital where I saw the 35-year-old man die, where basic equipments were lacking, the emergency ward had just 2 nurses, and filth was everywhere you stepped. There was a brand new spiral CT scanner and a gorgeous angiography facility that must have cost tens of thousands of dollars to build. More than one doctor told me that it was easier to get a new MRI machine than to maintain basic supplies and hygiene. Such machines have become the symbol of modern medicine, but to view them this way is to misunderstand the nature of medicine's success. Having a machine is not the cure. Understanding the ordinary, mundane details that must go right for each particular problem is. India's health system is facing the fundamental and mammoth difficulty of adapting to its population's new and suddenly more complicated range of illnesses. And what's required is rational, reliable organization as much as resources. For surgeons in India, both are in short supply. This situation is not unique in India, and that is what makes it a core conundrum for our time. Throughout the East, demographics are changing swiftly. In Pakistan, Mongolia, and Papua New Guinea, the average life expectancy had risen to over 60 years. In Sri Lanka, Vietnam, Indonesia, and China, it is more than 70 years. By contrast, because of AIDS, the expected lifespan in much of Africa remains under 50 years. As a result, rates of cancer, traffic accidents, and problems like diabetes and gallstones are exploding worldwide. Cardiac disease has become the globe's leading killer. New laboratory science is not the key to saving lives. The infant science of improving performance, of implementing our existing know-how is. Nowhere, though, have governments that recognize this. A surgeon in much of the world therefore stands on his own, with little more than a pen, his fine fingers, and his wits to cope with a system that barely works, and an ever-growing sea of patients. These realities are without questions demoralizing. The medical community in India has mostly resigned itself to current conditions. All the surgical residents I met hoped to go to the cash-only private sectors, where patients with the means increasingly seek care, given the failure of the public system, or abroad when they finish their training, as I think I would in their shoes. Many attending surgeons were plotting their escape too. Meanwhile, all live with compromises in the care they give that they cannot bear to tolerate. This is very sad to think that the doctors in India, they're already short in supply, but the current system are pushing them away from working in the public sector. Yet, despite the conditions, the surgeons have persisted in developing abilities that were a marvel to witness. I had gone there thinking that, as an American-trained surgeon, I might have a thing or two I could teach them, but the abilities of an average Indian surgeon outstripped those of any Western surgeon I know. What is your preferred technique for removing bladder stone? One surgeon in the city of Nagpur asked me. My technique is called a urologist, I said. On rounds in Nanded with a staff surgeon one afternoon, I saw patients he had successfully treated for prostate obstruction, diverticulitis of the colon, a tubercular abscess of the chest, a groin hernia, a thyroid goiter, gallbladder disease, a liver cyst, appendicitis, a staghorn stone in the kidney, and a cancer of the right hand, as well as an infant boy born without an anus, in whom he had done a perfect reconstruction. Using just textbooks and advice from another, the surgeons at this ordinary district hospital in India had developed an astonishing range of expertise. What explains this? There was much of the surgeons have no control over the overwhelming flow of patients, the poverty, the lack of supplies, but where they had control, their skills, for example, those doctors sought betterment. They understood themselves to be part of a larger world of medical knowledge and accomplishment. Moreover, they believed they could measure up in it. This was partly, I think, a function of Nanded's surgeons' camaraderie as a group. Each day I was there, the surgeons found time between cases to take a brief late afternoon break at a cafe across the street from the hospital. For 15 or 30 minutes, they drank chai and swapped stories about their cases of the day, what they had done and how. Just this interaction seemed to prod them to aim higher than mainly getting through the day. They came to feel that they could do anything they set their mind to. Indeed, they believed not only that they were part of the larger world, but also they could contribute to it. Among the many distressing things I saw in Nanded, one was the incredible numbers of patients with perforated ulcers.
In my 8 years of surgical training, I had only seen one patient with an ulcer so severe that the stomach acid had eroded a hole in the intestine. But Nandid is in a part of the country where people ate intensely hot chili peppers, and patients arrived almost nightly with the condition, usually in severe pain and going into shock after the hours of delay involved in traveling from their villages. The only treatment at this point is surgical. A surgeon must take the patient to the operating room urgently, make a slash down the middle of the abdomen, wash out all the bilious and infected fluid, find the hole in the duodenum, and repair it. This is a big and traumatic operation, and often these patients were in no condition to survive it. So Motor did a remarkable thing. He invented a new operation, a laparoscopic repair of the ulcerous perforation using quarter-inch incisions and taking an average of 45 minutes. When I later told colleagues at home about the operation, they were incredulous. It did not seem possible. Motor, however, had mulled over the ulcer problem off and on for years and became convinced that he could devise a better treatment. His department was able to obtain some older laparoscopic equipment inexpensively. An assistant was made personally responsible for keeping it clean and in working order. And over time, Motor carefully worked out his technique. I saw him do the operation, and it was elegant and swift. He did not do a randomized trial, which he presented at a conference which reviewed the operation to have fewer complications and a far more rapid recovery than the standard procedure. In that remote, dust-covered town in Maharashtra, Motor and his colleagues had become among the most proficient ulcer surgeons in the world. True success in medicine is not easy. It requires will, attention to detail, and creativity. But the lessons I took from India was that it was possible anywhere and by anyone. I can imagine few places with more difficult conditions, yet astonishing success could be found, and each one began, I noticed, remarkably simply, with a readiness to recognize problems and determination to remedy them. Arriving at meaningful solutions is an inevitably slow and difficult process. Nonetheless, what I saw was, better, it is possible. It does not take genius, it takes diligence. It takes moral clarity. It takes ingenuity. And above all, it takes a willingness to try. I find this part very inspiring because in life, we always think that, some people are very accomplished because they're just born very smart, but that's not the case because people who succeed are the people who are willing to take risk and are willing to try hard. So as long as we keep trying, we never quit after failures, we will end up accomplishing many good things. There was a 1-year-old boy I saw brought into the teeming Nandid surgery clinic by his parents, their faces wearing that distressing look of fear, helplessness, and fervent hope that I'd come to recognize in these poor, overcrowded hospitals. The child lay in the cradle of his mother's arm, disturbingly quiet, his eyes open but without interest or reaction. His breathing was steady but unlabored, yet unnaturally fast, as if a pump inside him were set at the round speed. The mother described repeated bouts of frighteningly violent vomiting. The emesis could burst out of him across the table. The doctor in the pediatric clinic had noted his head to be enlarged, with the circumference distinctly out of proportion to his small body, and made a provisional diagnosis that was confirmed on a skull X-ray. The doctor had severe hydrocephalus, a congenital disease in which the normal drainage of the brain is blocked. The cerebral fluid slowly accumulates, gradually expanding the skull, but also compressing the brain to relieve pressure. Unless surgery is performed to provide a new route out of the brain and skull for the fluid, the resulting brain damage becomes severe, advancing from vomiting to visual loss to sleepiness, coma, and finally death. But if surgery were successfully done, the child could live normally. The pediatricians therefore sent the child and his parents to the surgical clinic. The surgery department had no neurosurgeon, though, nor did it have the equipment a neurosurgeon would need. No drill to bore a hole through the skull, no shunt device with its sterile one-way through tubing to channel the fluid out of the brain, under the skin, and down into the abdominal cavity. The surgeons did not want to just let the child die. However, they gave the father instructions about the sort of device the son would need, and he managed to find a facsimile one in the local markets for 1,500 rupees, about $30. It was not perfect. The tubing was too long and it wasn't sterile, but P.T. Gawande, the chief of surgery, agreed to take the case. The child was brought to the operating room the next day, my last in Nanded, and I watched the surgical team perform. The tubing was trimmed to size and put into a steam autoclave. The anesthetists put the boy to sleep with an injection of ketamine, a cheap and effective anesthetic. A nurse shaved the hair from the right side of his head with a razor and cleansed his skin from head to hip with an iodine antiseptic. A surgical resident laid sterile cloth drapes down to frame the operative field. On a little tray under a long operating light, a nurse lined up the surgical instruments, silvery, gleaming, and it seems to me wholly inadequate to the task. Gawande had little more to work with than I would use to sew a minor laceration closed, but he took the scalpel and made an 1-inch incision through the skin and thin muscle and an inch above the boy's ear. He took a hemostat, an ordinary scissors-shaped metal clamp that surgeons normally use to grasp a small blood vessel or a suture thread, and began slowly grinding its tip into the child's exposed white skull. At first, nothing happened. The tip kept sliding off the hard, bony surface, but it began to find purchase, and over the next 15 painstaking minutes, he ground and scraped until a tiny hole through the skull appeared. He worked to widen the aperture, taking care not to slip and puncture the now exposed brain. When the opening was large enough, he slowly slid one end of the tube through into the gray and white matter of the brain and onward into the swollen fluid ventricle inside it. He took the other end of the tubing and snaked it under the skin of the neck and chest, down to the abdomen. Before popping the tube into the open space of the abdominal cavity, though, he stopped momentarily to watch the fluid of the brain flowing out of his new channel. It was clear and lovely, like water, like perfection. He had not given up, and as a result, at least this one child could live. And that is the end of our last chapter and this entire book. I definitely learned a lot from this book. All those medical advances, how people try to improve themselves in the field of medicine, and this book has been very inspiring and taught me so much about life in general, like how we should not give up when we don't have resources, when we don't know how to do anything. We gotta keep trying things. We should never give up hope, and we can always do better and improve ourselves despite where our levels are. So I hope you enjoyed reading this book with me, and I'll see you later when I read another book to you. Thank you.